So this presentation is basically focusing on the surgical technique of performing unicompartment knee replacement. So the indication of unicompartment knee arthroplasty is basically anteromedial osteoarthritis. So we know that the knee has got three compartments: the medial compartment, the lateral compartment, and the patellofemoral compartment. In early cases, frequently we see that the medial compartment is more commonly involved. Now, if the ligaments are intact, the ACL is intact, then usually it's the anteromedial osteoarthritis which is present, also known as AMOA. So, unicompartment or knee replacement is ideal for anteromedial osteoarthritis. And the criteria for diagnosis includes medial osteoarthritis with bone-on-bone disease, the ACL and MCL is functionally intact, and there is full thickness cartilage in lateral compartment. So that's a typical patient for unicompartment knee replacement. So here you can see that this patient is having medial compartment osteoarthritis. The lateral compartment is fine. It is a bone-on-bone disease, and it is correctable on valgus deformity. So once the valgus deformity was given, then this deformity was correctable. That indicates that the MCL is intact and it has not gone into contracture. It is correctable contracture. The lateral compartment is okay, though we are giving valgus stress, but this space is maintained. So the osteoarthritis is limited to anteromedial part only, no lateral compartment involvement, and he's got intact ACL and MCL. So the sequence of presentation will include the patient positioning, the skin incision. The different steps include osteophyte excision, tibial plateau resection, the femoral drill holes and alignment, femoral saw cut, the first milling of the condyle, equalizing the flexion and extension gaps, confirming equality of flexion and extension gap, preventing impingement, final preparation of the tibial plateau, final trial reduction, and cementing the component. Now we know that knee osteoarthritis is a highly prevalent condition worldwide. Especially in our country, knee osteoarthritis is very, very common. Now, it is a leading cause of musculoskeletal disability and is associated with activity limitation, working disability, reduced quality of life, and increased healthcare costs. There are damaged bones and cartilage, and that is resurfaced with metal and plastic component during knee replacement surgery. Now, total knee replacement is a very successful and a highly predictable surgery. Okay, but if there is involvement of only one compartment, then perhaps unicompartment knee replacement gives a very good result. It gives a faster recovery, fewer and less severe complications, and the function is much better than total knee replacement, because here the ligaments are left intact. So while in total knee replacement, you excise the PCL, the ACL, in unicompartment, all the ligaments are intact. You are just resurfacing the medial compartment. So the feel is much more natural in unicompartment knee replacement. The national joint registries have also demonstrated that in comparison to TKR, UKR has, the patients have shorter inpatient stays. The mortality rate ratio is definitely much, much less. And there are lower incidence of major complications such as infection and better outcome scores. Now the concept was started in 1950s when McEwer and McIntosh introduced the metallic tibial plateau. And then in 1972, the first contemporary UK where resurfacing of both the femur and tibia of a single knee compartment was performed by Marmor. Despite the theoretical advantages of the design, the survivorship rates were disappointing, with more than 30% of the patient undergoing revision surgery within 10 years. But then there were changes in the implant design, in the techniques, and over the course of years, surgeons have understood the biomechanics of knee in a better way. So with better instrumentation and better implant, the results of UK are now much better. So let's start with the surgical technique first. Now, for unicompartment knee arthroplasty, your limb should be free. So it should be hanging free by the side of the couch on a leg holder. Okay, so you should be able to flex the knee up to 110 degree and fully extend it, and the surgery will be performed with the knee hanging in this position. So you don't want to put the knee on the couch here with a bolster like you do in total knee replacement. Here the leg is hanging down in the air so that with gravity you can work better. With the knee in 90 degree of flexion, you first give a medial parapatellar skin incision from the medial margin of the patella to a point around 3 centimeter distal to the joint line, okay, by the side of the tibial tuberosity. Then you debut the incision through the joint capsule. At the upper end, extend the capsular incision medially for 1 to 2 centimeter into the vastus medialis, and then you excise the retropatellar fat pad. The first step is removal of osteophytes. So in medial OA, you get osteophytes on the femur, you get osteophytes in the notch. So the first step is with the help of osteotome, you carefully excise all these osteophytes, because these osteophytes, they impinge upon the collaterals, they tend the collaterals, and then the balancing becomes difficult. So the first step is removing the osteophytes. Especially you should be very careful while excising the osteophytes which are just beneath the MCL. So you can use a small osteotome to excise those osteophytes. Now this creates room to insert the saw blade into the intercondylar notch during the next step. Then you expose the front of the tibia in the lower part of the wound from the tibial tubercle to the rim of the plateau. Excise as much of the medial meniscus as possible. Do not release any of the fibers of the medial collateral ligament. Now that is the major difference between a unicondylar knee replacement and total knee replacement. In total knee replacement, you correct the deformity by release of the ligament. You release the MCL. But in UKA, you don't have to release the ligament. Whatever deformity correction you want to do, it has to be done with bony cuts. Okay, not with release of the ligaments. Then you apply the tibial saw guide parallel with the long axis of the tibia in both the planes, in coronal as well as in the sagittal plane. And the saw cut should pass 2 to 3 millimeter below the deepest part of the lesion. Now this is a small video demonstrating the tibial cut. So that's the femoral condyle. So you put a spoon which rests upon the posterior condyle. Now the posterior cartilage is intact and there is erosion only in the anterior part. Then you insert the tibial jig and you fix it to this spoon with the help of a D clamp. This is called a D clamp. And then you put 2 pins here to hold the jig in position. Now you can put 2 pins or you can even put just 1 pin so that it doesn't cause any stress riser in the tibia. Then you first take a sagittal saw and you cut and you make a vertical cut which is just by the side of the origin of the ACL, and then with the help of a small saw blade you remove the tibial plateau. Now it should come out as one piece, and you will find that there is erosion only in the anteromedial part. In the posterior part usually the cartilage is intact. So that completes your tibial cut. Then we come to the femoral part. So first you have to make the pilot hole in the femur. Now this pilot hole is made 1 centimeter above the anteromedial part of the notch, or over 1 centimeter superior to the attachment of the PCL. Okay. So with the knee in about 45 degree of flexion, you make a hole in the intramedullary canal of the femur. This is situated 1 centimeter anterior to the anteromedial corner of the intercondylar notch. Then you insert the intramedullary rod till its shoulder is stopped against the bone. Then there is a femoral saw block which is fixed, which is inserted into the hole which is prepared and tapped home, and with a 12 millimeter broad sagittal saw you excise the posterior facet of the femoral condyle. Then now in unicondylar knee replacement, there is sequential milling of the femoral condyle. So in tibia, you take one cut with the help of a saw, but in femur, you do sequential milling with the help of special mills. Now, for that, you have to use this kind of device, which is known as spigot. Okay. So first you insert the zero spigot, which has the thickest flange, into the large drill hole and tap it against the flange, abuts against the bone. Now you will see all this in the video. Then you maneuver the spherical curette onto the spigot as shown in the femur, or this is also known as a mill. Take care to avoid trapping the soft tissue. So let's see the video demonstration. So first you drill the pilot hole in the femur, which is around 1 centimeter above the intermedial corner. Then you widen it and put this intramedullary rod here. Then there is this special connector device which is needed for making the pilot hole in the femoral condyle. So you make two holes, which is in the middle part of the medial femoral condyle. So it is in the middle third of the medial femoral condyle. And then with the jig, you first cut the posterior part of the condyle. So you have now taken the posterior cut and you haven't taken any distal cut. This posterior cut is usually equal to the posterior part of the femoral implant. Then you insert zero spigot and you mill the distal part. Then you insert the tibial base plate and the trial implant, and then you put this spacer first in flexion. So suppose this part is 4, you are using 4 spacer in flexion. Now as you have not excised anything distally, so you won't be able to put the 4 spacer in extension. So you measure it. So you measure again with another spacer. So suppose in extension it is, so suppose you have found that the number 4 spacer is comfortably going in flexion and number 0 spacer is going in extension. So 4 minus 0 is 4. Then you take size 4 spigot and then you mill over it. So that means that it will now remove 4 millimeter of extra bone. Again, you put the femoral trial implant and the tibial trial implant and check the balancing with the help of spacer. Now you will find that type 4 spacer is going comfortably both in flexion as well as extension. Now you don't need a very tightly fitting spacer, okay? Because if you take a very tightly fitting spacer, that means it will open up the medial condyle, medial compartment, and it will put more pressure on the lateral compartment. So one of the cause of failure of UK is arthritis on the lateral side if you have used a very large spacer on the medial side. So this is again the same thing. With the leg in 90° of flexion, insert the tibial template and apply the femoral trial component to the milled condyle. So we have placed the tibial base plate and the femoral implant. Carefully measure the flexion gap with the feeler gauge. So this is a feeler gauge and it has got markings on it. So you start from 1, 2, 3, 4 and 5, 6. So remove the gauze. It is important to remove this feeler gauze before you extend, because initial milling is 0. So you may be getting 4 or 5 space in flexion, but in extension you will get 0 or 1. Then you slowly rim it to the desired size so that your flexion and extension gap are properly balanced. After you have done it, you will see that there is there can be impingement because of this bone. So you have to trim the anterior and posterior condyle of the femur to reduce the risk of impingement of bone against the bearing in full extension and flexion. So anteriorly you have to remove this part of the bone, and posteriorly you have to use this special type of chisel to remove the posterior osteophyte. So till now we have understood what we have done. We have taken the tibial cut. We did first initial milling with a 0 spigot. Then we checked the balancing in extension and flexion. Now we found out the difference in the space in extension and flexion, and then we milled it further so that both the extension and the flexion gap is balanced. Then you can see that there is this bone which is abruptly abutting this the milled bone. So you have to remove this part, or you have to at least so you put this device to remove the impingement. Over that you ream it so that you get a gradual thing like this. Posteriorly also you use this special kind of chisel to remove the osteophytes. Now it's very important to remove all these bones because they may cause impingement and it will dislocate the spacer. Then comes the final preparation of the tibial plateau. So you insert the chosen size of the tibial template and position with the posterior margin flush with the posterior tibial cortex. This is facilitated by passing a small hook over the posterior margin of the tibia. Then fix the template with a transfixing tibial nail. Use a reciprocating saw blade to make 10 mm deep cuts along both sides of the slot in tibial template. Make a third oblique saw cut in the slot to facilitate removal of the bone. So we have taken the tibial cut, but then you have to make a slot in the tibia where the keel of the tibial implant will go. So that is facilitated with the help of this pin and this special saw blade. Then after making the cut with saw blade, you have to remove all the bone in this slot so that the implant can sit properly. Insert the tibial and femoral trial component and ensure that they are fully seated by tapping them home with appropriate impactor. So femoral implant is impacted at 45 degrees of flexion, and for impacting the tibial implant you have this kind of special device. Then insert the trial meniscal bearing of the chosen thickness. Once you have done the trial component and you are happy with the reduction, then you take the final implant and you cement it. Before cementing, as in a total replacement, you make small holes so that the cement can infiltrate properly and you get a good hold of the implant over the bone. In this unicondylar, it's better to do cementing separately because you are working in a very small space, and it's very important to remove all the cement particles because this spacer is a mobile bearing spacer. So if there are any osteophytes or any cementophytes, it may impinge upon this spacer and it may dislocate it. So take time, do both the cementing separately and do it properly. In post-operative phase, care must be taken to make certain that all the cement is removed from the joint. So that's why it's important to do it in 2 steps. And most patients are discharged 1 to 2 days after this procedure, and they can manage just with a cane. Now, complications in UK are usually because of surgical errors. Different surgeons have different failure modes, suggesting that they repeat errors. The high volume surgeons and centers have fewer complications than low volumes. So it's a very exacting surgery, and that's why it's very important to stick to the principles and the technique. Now, the common complications the common reasons for revision are lateral compartment osteoarthritis. So if you have overstuffed the medial compartment, then you will get lateral compartment osteoarthritis. So it's always suggested that you should undercorrect the deformity. You should not try to overcorrect it. Dislocations can happen if there is the balancing is not okay, or if there are any osteophytes or cement particles which have not been removed. So that can impinge upon the osteophyte, they impinge upon the spacer, and that can cause dislocation. Then you can have unexplained pain. Usually what's happening that the load is coming on a very small surface area because you are just replacing the medial compartment. That on the tibial side, the base plate is very small. So a lot of force is coming on that small area. So that's why it causes some pain over the medial part, and that takes around 3 to 4 months to go sometimes. Rest of the complications are common to all other orthopedic surgeries. So the advantages of UK over TK, it helps in preservation of bone stock. You have seen that a very small amount of bone is removed. Secondly, most important thing is that there's maintenance of more normal joint kinematics because the ACL and the other ligaments are intact. Okay, so the patient feels as if his knee is natural. Because the ligaments are intact, so proprioception is much better. They have a better range of motion, faster recovery, and it's also more cost effective. Disadvantages, uncemented systems have got high failure rates, so nowadays cemented system is preferred. Patient selection is the key to success of unicondylar knee arthroplasty. You have to have an ideal patient for UK. So the varus should be less than 10 degree. The ligament, you should not try to overcorrect the deformity. You should always try to undercorrect it, and you should never release the ligament. Okay, whatever deformity is there, you should try to correct it by boning cuts, not by releasing the ligament. Major pitfalls: osteoarthritis in the contralateral compartment is contraindicated for UK. Overcorrection during medial UK is associated with progression of osteoarthritis in the contralateral compartment and therefore should be avoided. And residual post-op access of more than 8 to 10 degree of varus following unicompartment knee arthroplasty increases the rate of failure from polyethylene wear and loosening. So clinical indications of UK that there should be less than 10 degree of varus deformity. Range of motion should be at least 90 degree without a flexion contracture. There should be a medial instability only. The patient should not be obese. And more importantly, that there should be unicompartmental pain only. The contraindications include rheumatoid arthritis. In fact, it should not be done in all inflammatory arthritis because in inflammatory arthritis, all the compartments of the knee are involved. If you just do unicompartmental knee arthroplasty, then it's not going to relieve him of his pain. Non-localized knee pain, you should avoid there. Decreased range of motion with flexion contracture, in those cases again, UK should be avoided. In very active lifestyles, person when sports, perhaps it should be avoided. Obesity, knee instability with absence of ACL. So it's very important that ACL is intact. If your ligaments are not intact, then this is going to fail. It's going to fail very quickly. And unrealistic expectations regarding the activity level and longevity of the prosthesis. So I thank you for your attention. Thank you.